In hematology, several key methodologies are used to analyze cells. The first is the electronic impedance method, also known as the Coulter Principle. When a cell passes through an electric current, it creates a pulse that is proportional to the size of the cell. This principle is widely used for cell counting and sizing, as well as for generating a three-part differential that distinguishes lymphocytes, monocytes, and granulocytes. In this system, red blood cells and platelets are counted in the red cell bath. Differentiation between them is based on size, determined using thresholds. The mean corpuscular volume, or MCV, is measured directly because the size of the pulse corresponds to the size of the cell. White blood cells and nucleated red blood cells, if present, are counted in the white cell bath, where the red cells have been lysed. The second methodology is optical scatter, which is the basis of flow cytometry. Here, a high-intensity laser beam of a single wavelength is directed at the cells. This method is used for detailed cell analysis and differentiation. Populations of white blood cells are identified based on how they scatter light. Forward scatter relates to cell size, and side scatter relates to cell complexity or granularity. The third methodology is cytochemical staining. One example is peroxidase staining, which helps identify different white blood cells based on their degree of peroxidase enzyme activity. The red cell histogram is a graphical representation of the distribution of red blood cell sizes, measured as mean corpuscular volume, or MCV. The normal curve is shown as a smooth, bell-shaped distribution. This represents the expected size range of normal red blood cells in a healthy individual. A left shift on the histogram indicates the presence of microcytes, or abnormally small red blood cells. The peak shifts to the left, toward lower MCV values. Conditions like iron deficiency anemia or thalassemia can cause this left shift. On the other hand, a right shift represents macrocytes, or abnormally large red blood cells. The peak moves to the right. This pattern can be seen in conditions such as vitamin B12 deficiency, folate deficiency, or liver disease. In summary, normal curve, centered around 90 femtoliters. Left shift, microcytic cells, smaller than normal. Right shift, macrocytic cells, larger than normal. By examining the histogram, clinicians can quickly identify whether red cells are predominantly normal in size or shifted toward microcytosis or macrocytosis, guiding further diagnostic evaluation. A bimodal curve in a red cell histogram indicates that there are two distinct populations of red blood cells present in the sample. For example, imagine a patient with iron deficiency anemia who has received a blood transfusion. In this case, the patient's own red cells are microcytic, or smaller than normal, which produces a left-shifted curve. After transfusion, the donor's normal red blood cells are also circulating in the bloodstream, producing a second peak in the normal range. The result is a bimodal histogram, one peak representing the patient's microcytic cells, and another peak representing the transfused donor's normal cells. This pattern is a classic indicator of mixed red cell populations and helps clinicians interpret the patient's hematologic status in the context of recent transfusion therapy. When interpreting the white cell three-part differential histogram, automated hematology analyzers may generate flagging indications. These flags help the technologist identify when abnormal populations might be present. The R1 flag usually suggests the presence of nucleated red blood cells or platelet clumps, which can interfere with the lymphocyte region of the histogram. The R2 flag may indicate blasts, immature granulocytes, or variant lymphocytes. This suggests possible hematologic disorders, including acute leukemias or reactive lymphocyte responses. The R3 flag appears when there are immature granulocytes, an increase in eosinophils or basophils, or other abnormal cell populations. This can reflect infections, myeloproliferative conditions, or other pathologies. In summary, the histogram curve shows the relative size distribution of lymphocytes, monocytes, and granulocytes. while the R flags alert the technologist to possible abnormal or interfering cells that require further review under the microscope or confirmation by additional testing. The 5-part white cell differential scattergram is generated by automated hematology analyzers, such as the Beckman-Coulter systems. The principle combines impedance for cell counting, along with VCS technology, which stands for volume, conductivity, and scatter. Volume is measured by direct current impedance. Conductivity is measured by radiofrequency penetration of the cell, reflecting internal composition such as nuclear structure. Scatter is measured by laser light scatter, reflecting cell granularity and surface characteristics. With this combination, the analyzer can differentiate the 5 major white blood cell populations. Lymphocytes, which appear as small cells with low volume and low scatter. Monocytes, larger cells with moderate scatter. Neutrophils, which show higher scatter due to their granules. Eosinophils, which stand out due to their distinctive granularity. In addition, platelet clumps and nucleated red blood cells may appear as interfering populations flagged by the analyzer. This method allows precise automated classification of white cells, guiding clinicians in diagnosing infections, hematologic disorders, and immune responses. The Siemens Advia hematology analyzer uses a combination of light scatter, peroxidase staining, and differential lysis to identify and classify white blood cells. Light scatter helps separate cells based on their size and internal complexity. Peroxidase staining is an enzymatic method that highlights neutrophils, monocytes, and eosinophils based on their peroxidase activity. Differential lysis is a special technique used to identify basophils, since they lack peroxidase activity. On the scattergram, we see distinct clusters for lymphocytes, which are smaller and cluster at the lower end, monocytes, with moderate scatter and staining, neutrophils, which show strong peroxidase activity and appear in a separate region, eosinophils, which are highlighted by both scatter and staining, platelet debris, platelet clumps, and nucleated red blood cells, which can create interference signals in the lower corner of the plot. This system provides precise classification of white blood cells by combining physical, enzymatic, and chemical methods. When it comes to nucleated red blood cell and reticulocyte counts, automated hematology analyzers use different technologies depending on the platform. With the Beckman-Coulter system, 3 principles are combined. The first is impedance, which measures changes in electrical resistance as cells pass through an aperture. The second is VCS technology, which stands for volume, conductivity, and scatter. This allows measurement of cell size, internal composition, and granularity. The third is supravital staining, which highlights reticulocytes by staining their residual RNA. With the Siemens Advia system, the approach is slightly different. It uses a combination of light scatter and absorbance, which helps differentiate cell populations. Like the Beckman system, it also employs supravital staining to identify and count reticulocytes. In summary, both analyzers rely on supravital staining for reticulocytes, but the Beckman-Coulter uses impedance and VCS technology, while the Siemens Advia uses light scatter and absorbance. Sometimes, complete blood count results can be misleading because of sample-related or technical issues. For red blood cells, false elevations can occur when the white cell count is extremely high or when giant platelets are miscounted as red cells. False decreases can occur in the presence of schistocytes, microcytes, cold agglutinins, or gross hemolysis. For white blood cells, false increases may be caused by nucleated red blood cells, sickled or resistant red cells, giant platelets, platelet clumps, or abnormal precipitates. False decreases occur when the white cells are fragile and break apart. For platelet counts, False increases can happen when schistocytes or microcytes are counted as platelets, while false decreases occur due to platelet clumps or giant platelets being excluded. For hemoglobin values, false increases can result from lipemia, very high white counts, sickle cell resistance, abnormal globulins, or icterus. False decreases may be caused by sulfhemoglobin. For MCV, false increases are commonly seen with cold agglutinins or very high white counts. And finally, for MCHC, false increases may be due to cold agglutinins, lipemia, or icterus. In summary, erroneous CBC results often arise from interferences such as clumping, abnormal cells, lipemia, hemolysis, or extreme leukocytosis, and must always be correlated with the blood smear and clinical picture.